live right now.
It's just me.
It's just.
And then somebody tinkering around in the background. Well, that's just really not where you can see it well, though.
No.
Because then it looks like I'm looking a different place, see?
Yeah. Oh, we'll look at that for now. But it's cool.
We're here.
Probably works a little better for you.
Monday after your favorite time of the week, Monday afternoon with Dr. Gawain and Dr. Mark.
It's my favorite time of the week.
On the Auburn Medical Group YouTube channel, talking about medical topics with live chat, because we do it live so that viewers can actually chat in their comments and questions, which they're doing right this very moment.
Laura Spurs says hello.
Laura Spurs is
Who
one
is
of
a
our channel members, so we're really happy. I'm sorry, I'm acting like I'm on caffeine.
Did you have caffeine today?
In that hot chocolate? Oh, that...
you had a tea. Yeah, that smelled nice. Smelled tasty. Did it have caffeine in it?
It didn't say it's caffeine content. That brand of tea doesn't tell you.
Oh.
Well, actually...
I could tell you.
It tells you if it's...
Anyways.
Okay.
So.
I'm so glad to be with you today.
It's a good day. It's a Monday.
Good.
It's how many days till Christmas?
Had some
9 days till Christmas.
That's good.
Hope all your shopping's done. Haven't you started mine? Not that I do. My wife is great and does most of our shopping, so I just need to get her something.
Yeah, that's the tough one, isn't it?
Yeah.
We'll have to talk about that offline.
Yes.
But I would want to give a little shout out, although she may not have commented yet, to Bianca, our channel member Bianca.
Laura, Lindsay Antwine, and Bianca is here.
Bianca, we were just watching your video titled Me and Less. And you know what we came up with? Sometimes less is more, which is probably not a real, you probably hear that all the time.
He said that. Bianca did say, she said, serious question.
Oh, what's that, Bianca?
I've seen a lot of specialists, but I saw a hematologist and had blood tests and was supposed to get follow-up appointments on the 2nd of January, but they rang. And I go tomorrow instead. Do you think it will be bad news? So they called you in earlier based on some blood tests you had.
I wouldn't say necessarily bad news. Knowing what hematologists look at, it's probably something that's going to require more testing. That's
usually how it goes with hematologists.
I'm sorry.
That's probably what the answer will be.
You get that first test, and it comes back with some results that are just not quite normal. Doesn't mean bad, it's just not normal. And then they have to follow that up with more tests. And that's why I try not to order tests unless we know what we're going after. And
I just had that conversation with a patient today.
Yeah.
Yeah, his VA doctor ordered up a test and said, oh, it's a false positive, without doing any further testing.
Why did he order it in the first place?
Exactly. That's exactly what I told the patient. I was like, why did he order it if it's a false
Why did you order it in the first place?
Yeah.
If you're going to say a positive is a false positive, why do you order it in the first place? I want all of our audience to hear this and understand the concept.
Get on your soapbox.
If when the answer comes back, either way, you're doing the same thing, why do you order the test? And so if any of you are my patients and you want to order a test, but you don't want to do what would be indicated if the test goes one way or the other,
right?
Why do you want the test? It just introduces questions that lead to no good.
Agreed. There you go. That's why we don't screen for everything under the sun.
No. There are certain screening tests we do get. Those recommended by the NIH, by the United States Preventive Forces Task Force, which you can find for yourself on the internet and find what their recommendations are for screening for certain things. And there are certain things that there are screening recommendations for, and they're good. Not that many. Okay. Are we getting any other really good comments and questions from our channel members?
Lindsay says she hasn't bought a single gift either.
Lindsay! Nothing? Nothing?
Bianca says her iron levels are fine and she's not diabetic. Well, that's great.
Very good.
I guess we'll find out what the hematologist has to say.
Good. Yeah, we're glad for that.
On tomorrow.
Okay.
So we'll get off of our soapbox on unnecessary tests and maybe talk about IBS.
Let's talk about that.
IBS. What is IBS? As opposed to IBD.
Yes.
That's a very
yes.
big distinction there.
Let's make sure our audience knows that IBS, irritable bowel syndrome, is not to be confused with IBD, inflammatory bowel disease, which comes in two major flavors of
vanilla and chocolate. Oh, Crohn's and ulcerative colitis.
Okay.
Chocolate is usually...
Never mind. I know where this is going because I know how you tell the difference between the two, and it has nothing
chocolate and strawberry.
It has nothing to do with a soft serve machine.
Anyways.
I'm sorry.
Oh, wow.
Well, at least we say our channel isn't for children, so.
Yeah, there was, our
Soft
monetization for this video. Anyways.
Flew away.
We always watch it. So,
yeah.
With that in mind, make sure that you write us a super chat.
Super chat. So we feel like somehow we should keep doing this inappropriate reference to.
Oh my goodness. Anyways, back to IBS, not IBD.
Okay.
IBS. What flavors does that come in?
It does. It actually comes in two flavors. It comes in the diarrhea predominant and the constipation predominant.
Yeah, IBS-D or IBS-C.
Oh, really?
Or mixed. You can actually have both, where it alternates between the two.
That's the handle in the middle.
That's horrible. It's horrible. Nothing's moving. Pull the handle down.
Why is it all I can think of is my favorite frozen yogurt place in downtown?
Oh, somebody says they have IBS-D. Can stress make it worse? Hey.
Let's talk about that.
Oh, that's all you're going to say today. Yeah, let's talk about that. Yeah. So IBS-D. Well, let's talk about IBS just in general. So we talked about the different types: diarrhea, constipation, or mixed, where you get a little bit of both. But IBS is a diagnosis of exclusion. So it is one of those where you have symptoms. So the symptoms are typically either diarrhea or constipation or both, with pain in the abdomen, usually relieved with having a bowel movement, sometimes having incomplete bowel movements and not feeling like you've fully evacuated.
That's frustrating. I hate that feeling.
Professional term.
For tenesmus.
No, don't Google that. And
at least don't do an image search if you do.
Oh, geez. Anyways, so IBS. That's essentially the symptoms, and it's not due to something else. So it's not due to the IBD. It's not an inflammatory disease. Usually, IBD, inflammatory bowel disease, has bleeding. That's the common symptom that people see with it, and they get diarrhea too, but usually bleeding. And
probably serious systemic symptoms like sometimes fever and weight loss and
you do not get those with IBS. You do not get those. So sometimes you have to do tests to make sure it's not something else, like a sensitivity, some stool tests, some blood tests. Sometimes you even need a colonoscopy to make sure nothing is going on within the colon.
I kind of, because it's a diagnosis of exclusion, which, by the way, anytime somebody says diagnosis of exclusion, it's totally legitimate for you to say, "Oh, come on!"
Like they're yelling at us right now.
Am I wrong?
Toss their cell phones across. Yeah, you're right.
Diagnosis of exclusion.
Yeah, like fibromyalgia. Anyways, diagnosis of exclusion means we've excluded all of the diagnoses, all the other diagnoses that we can actually have a test for.
Anything that's a positive, definite test that goes with it.
And kind of come up with it. Now, there are some criteria that you can fit under, like a couple different criteria where they say you have to have it on a certain amount of days per month for 3 months, like at least once a day, and then you have relief with your bowel movement. But I don't know how useful those are. I don't use them that often. It's usually taken care of by a primary care doctor. The GI guys don't like these.
Except for the exclusion part, because you really...
Except when you need the testing done to make sure it's nothing else.
If you're really going to be sure that it's not something else, somebody has to look in there with a scope.
Yeah, right.
Just the way it is.
And often there's gas and cramping and that sort of stuff too.
Yeah.
So,
thank you for that pause.
We work in the same office. I didn't make a gas joke.
Thank you.
All right, anyways.
So you've got stress.
Stress. So yeah, that is somebody was asking about that. Can stress make it worse? Yes, because there is a psychological component to IBS, that it is a nervous bowel, as it were, that being under
nervous
stress or being nervous or having a psychological disorder can actually worsen it. So if you are an anxious person or depressed person, that can affect your bowels and cause IBS. And it's actually fairly common. It's like 10% of the population. More than 10, that's pretty common.
What if every time you go to a bookstore or when you go running?
Does that happen to somebody that we know?
That's something else.
I used to have that problem when I ran.
I know.
Not anymore. I do well now.
When you were running, you needed to run.
Well, the problem was I had to eat while I ran. And all that stuff that you eat while you run when you're training for a marathon, that stuff just goes straight through you.
It's osmotically active.
It's supposed to be easily absorbed and really, really high in sugars, and they're just not good for you.
You know, there's a cardiologist who sometimes works out of the office in Auburn that I've talked to you about.
Yeah.
Who did a marathon the other weekend.
Oh, right. Yeah.
He talked about purposely testing all of those things. He found out which ones they're going to give you, the little glucose gels or whatever along the way. He tested each one because he was concerned about that happening.
So dude, it's a horrible thing while you're running.
He knows which ones he can take during a marathon.
Yes.
And
even though they have...
And be able to keep running instead of running.
The porta potties while you're running, you don't want to... That cuts into your time.
Yeah, it's not like there's a master stopwatch that you hit stop on.
I got to go to the bathroom.
And then you hit restart again after you run out of the...
keeps going.
No.
Yeah.
So you talked about stress.
So, stress. Yes. Also, foods can affect it too. So, it can be variable how foods affect it. Often, you can read those. I'm not reading them. Sorry, not keeping up with them. But the fiber can be good, and oftentimes is, but in some cases, fiber can actually make it worse. So you kind of need to experiment with that. Often they say more fiber is good for you. What are you commenting on?
Lindsay Antwine. I love that two highly educated, accomplished, intelligent doctors are not above bathroom humor.
Oh, no.
Crying, laughing emoji. This is why I'm here. Lindsay, you're in the right place.
Or is it that bathroom humor is not below us? Are we just meet in the middle?
I'm not done.
Keep reading.
Keep going.
So there are some diets that can help out with it. And so first is a lot of testing, finding out what helps for you. But there is a diet called the FODMAP diet, FODMAP, which stands for...
Fiber.
Nope, not even close.
Fruit.
It's actually fermentable monosaccharides and polyols.
It's not like the brat diet where each letter is a food.
Right. No, it stands for some weird thing. FODMAP.
Yeah. And actually, you want the anti-FODMAP.
Right. So those are the things you're trying to avoid, the FODMAPs, those fermentable oligodimonosaccharides and polyols.
And what are they in?
Actually, a lot of fruits have them.
What'd I say?
Yeah. Yeah, so you do need to be careful in that regard to the fiber you're getting. It's certain fruits you need to avoid. You can look it up. Actually, go to my blog and check it out. I've got a nice link there to the actual Stanford handout on the FODMAP diet. That's I believe, where it was developed. And it works very well. I have a lot of my patients on the FODMAP diet. They say that it works well for them. So that's kind of lifestyle stuff. Oh, and just general lifestyle stuff as well. So making sure that you have low stress, making sure you're sleeping well, eating healthy like we talked about. Exercising helps for this too. Avoiding smoking, that's a very important one too. Smoke is a pro-inflammatory thing, so avoid that. Yeah, that's all lifestyle stuff. Medications. What medications do you use?
Okay, so if diet and stress control aren't getting us the control that we want, I will consider either a tricyclic antidepressant.
Yep.
Or an antispasmodic.
Like Bentyl?
Mm-hmm.
Yeah, that's my go-to for that.
Further down on the list would be even an SSRI.
Right. Yeah, I don't consider SSRIs first line for that sort of thing, unless they have a clear depression, like a clear depression or anxiety. If it's just kind of mild, then I go more towards the tricyclic antidepressant. So that's like amitriptyline or nortriptyline. Maybe you've heard some of those. They have almost this neurologic component where they can control nerve type issues, and that is one of the things that's postulated.
I think it has to do with the serotonin receptors
within
the gut.
Yeah. Right.
Linzess, which
it's a newer one, yeah.
I don't prescribe that. I leave that to the GI doctor for the harder to treat cases.
Right. Yeah, those newer ones, they're expensive, first of all, so we try to avoid them. And oftentimes we'll start out with over-the-counter stuff. Metamucil can be very helpful as a fiber supplement if you can't do any of the fibers from the fruits and vegetables. So that's a good way to get it. And then from there you can progress on. If you do have the constipation form, you can do some of the over-the-counter, what's the word I'm looking for?
Like a stool softener or
stool softener. I like Miralax. That's kind of the one my go-to. I like Miralax. I don't know what you like.
You mean to prescribe?
Yeah, well, not to prescribe, but just recommend. I don't prescribe Miralax.
I like Metamucil.
Yeah, well, that's always my first go-to because that's safe. I mean, Metamucil is extremely
and it tastes good.
Safe. I don't think Metamucil tastes good. Are you talking about that orange stuff?
Yeah.
It's like, it's so nasty.
I get the sugar-free and big heaping teaspoon and a glass of water, mix it up real good.
To each
it
his
tastes good.
Try it out. Let's see. Are you on team nasty Metamucil or team
nasty? Okay. Here's the problem with Metamucil. you have to prepare it correctly. Yeah, we have some comments we have to get to there.
Okay.
It does require some learning. Yes. I will say.
So are you saying I'm just not learned enough to enjoy Metamucil?
It takes a while to, I don't measure. I just kind of look at the spoon and I look at the glass of water and how much is in it and just do it. I can't tell you how many ounces it is. I can't tell you how many grams of Metamucil it is. I eyeball it and it works. Okay, maybe eyeball is not the right anatomic.
That's not anatomic at all.
Anatomic analogy to use when we're talking about this. Anyway.
Nice.
Anyway, by the way, Laura Spurs likes
they also have fiber pills, so you don't need to taste them if you just want to take a glass of water.
Comments and questions.
Ulcerative colitis. Laura Spurs, what did you want to? I've been diagnosed with ulcerative colitis and diverticulitis, also, and microscopic. Oh no, that was somebody else that said microscopic.
The microscopic colitis. Now,
right.
I'm not sure where to go with microscopic colitis.
That's only diagnosed by biopsy on a colonoscopy.
So, are we talking about in IBD?
I believe so. Yeah, that is
a microscopic colitis.
Yeah, that is a true IBD.
Okay.
What is somebody saying about blood?
And the IBDs, they're usually treated with like steroids and other immune modulators, salicylate.
Yep.
These are things that
different treatments.
I'm not usually putting people on these medicines for GI diagnosis. It's usually the gastroenterologist who's doing it.
Yes. Somebody's talking about sodas and coffee. Bad for irritable bowel syndrome. Very bad.
Coffee it stimulates.
Yeah, it does.
Sometimes it can be used therapeutically.
That's right. Like if you want to have a bowel movement before a marathon.
Or you want to feel very uncomfortable when you're in the room with a patient, a couple patients into the morning. Just saying.
That works too.
As one of the nurse practitioner or PA is wanting you to see a patient with them, and you're just kind of moving around.
One second.
I'd love to. Can I get back to you on that?
Oh man,
I'll be right back.
Somebody says if you mix Metamucil into orange juice, it helps mask the taste. Mask the taste. There you go. That's what I'm talking about. She's on team nasty Metamucil. Just saying. You can take it in pill form with water and get it that way.
It takes like 5 or 6 capsules.
It does, yeah. Which don't taste at all.
Okay, it tastes like Tang. Anybody grow up with Tang? You know, the astronauts drink? Never mind. This is the wrong audience. No, actually, most of our audience is older than us.
I know Tang.
Okay, you do?
Yeah.
Yeah, that's what it tastes like.
Tang is not good. I'm just saying.
Okay.
All right, anyways.
I think it's good.
Yeah.
And it does wonderful things. It keeps the world moving.
That should be their slogan.
Oh, it should be.
Metamucil makes the world go round.
They should.
Metamucil keeps the world moving.
There
you go.
I should be the Metamucil spokesperson. I am an evangelist for Metamucil. I spread the word. Make the world a better place.
Okay, can't take it. All right.
If you were to die today, would you know that your colon was empty? I'm the Metamucil evangelist.
If I'm dead, does it matter? If I'm dead, I don't want to lose the contents of my colon afterwards. Retain some of my dignity.
It doesn't matter. It totally doesn't matter. They're trained.
Doesn't taste like Tang. Stacy agrees with me. Even though
it's better.
Tang's still nasty. Better? Oh man. I don't feel like I'm going to win this argument.
Good Metamucil in the morning and the evening, and oh man, the world is so right. I don't even know what the name of the company is that makes it.
A normal bowel movement is something that many people take for granted, because then you see patients that have bad bowel movements,
my goodness.
like IBS with constipation, and they haven't had a bowel movement in a week, or like diarrhea where they're going 16 times a day. Oh my goodness. A normal bowel movement is...
Yeah, young, well, like us.
Yeah.
Us and younger, we really don't appreciate what we have with just our bodies working normal. We hear it every day.
That's right.
It's usually older patients, and man, it's all they think about.
It's miserable. Life is lived BM to BM.
Well, yeah. They give you all the details of the color and the firmness.
Yeah.
Water content.
It's pretty amazing how knowledgeable.
They keep journals, and well, the GI doctors tell them to.
Yeah.
But man, be thankful. You know, medicine is just every day finding something new out that I'm so glad I don't have, or do have. You know, as the case may be. If you keep the right mindset, medicine will make you the most thankful person you can be.
Yeah. Yeah. Yeah.
Yeah. Yeah.
Lindsay Antoine wanted to chime in and say your funeral director will aspirate the contents of your abdomen before burial. So don't worry about it.
See, it's not.
I'm not worried about that. I'm just worried about losing it before the aspiration.
With all your family around your bed as you take your final breath, and then
in one way, and then out the other.
And your final.
Hey.
Yes.
What?
Oh my goodness! Wait! Why is it? I have to do it, man.
Oh.
What?
What is going on?
Why is that not working?
Explain
to everybody what's...
Ooh, it's a high five. Laura Spurs, thank you. So we just got a... I'm waiting for it to go off to say what would just happen. Hey, look at that. Look at that.
There we go. Well, I don't know how to turn it off.
Well,
so that it'll come back on again.
Oh, when you turn it off for good so you don't restart the this then that thing.
But thank you, Laura. You make the show interesting.
Yeah, hopefully we are.
I guess it was...
That makes up for our demonetization of this video with our inappropriate jokes.
Let me look at that.
Good job. High five, that's what is going on there.
High five, Laura.
High five.
High five.
But I'm living on Imodium at the minute. I'm living on Imodium at... Somebody's living on Imodium. I'll keep your identity secret, even though people can look it up right now.
They can look it up.
Sometimes, Imodium is needed. And that's another medication that's sometimes used for IBD, IBSD. I can get those right.
IBS, diarrhea.
Yeah, just to slow it down. Imodium's pretty safe. But you don't want to overdo it, because then you'll swing to the other
so
side.
So often that happens.
Oh man! And then people say, "Oh,
so often
I was having diarrhea. I started taking Imodium, and now I haven't had a bowel movement in 5 days."
With severe constipation, people have the water content seep past the solid matter, and they have these uncontrollable spills that occur in their clothing. And so they go, "Oh, I don't have constipation, I have diarrhea." And so then they'll start taking Imodium and they'll make it worse.
Right.
So usually when an older person comes in, they describe this erratic bowel movement stuff going on, and constipation is a component of it. I have to be convinced that it's not constipation by a whole lot of information. Otherwise, I'm just assuming they're constipated and they had the spillover event.
Yep. Yeah.
And they need to keep treating it like constipation if they're going to get past the logjam, so to speak.
Yeah. Anyways,
I'm trying to figure out.
we have some fans of Imodium.
I want.
Yeah.
Imodium?
Sometimes when you got that IBSD, you need it to be able to function, to go out. I have people who say, I can't even go to the doctor's office without when they're having a horrible exacerbation. And already Sheldon agrees.
They
it's
can't
hard
go in
to
public.
Work when you don't know when you can't control yourself.
Yeah, because it's going to just no warning.
I have patients who are like, I know every stop from here to wherever they're going because I've got to stop and have my bowel movement.
Between Sacramento and Newcastle or whatever.
Yeah, right. Yeah, because they got to do it.
Okay, I don't know.
Which is miserable. But like I said, there are treatments. So see your doctor, talk about those treatments. Sometimes we have to use medications. Most of the time we don't. Most of the time we can get pretty good control with just those lifestyle changes. So work on those.
For most
always
people.
do those.
Yeah.
That's the big thing.
Okay.
I think that's what it comes down to. So, but if it isn't getting better, or if you have any really bad things, blood, severe abdominal pain,
fever,
you see your doctor.
Weight loss,
and anything that's kind of out of the normal, then see your doctor soon, because it may be something else that needs to be worked up and figured out.
Thank you for a fun topic.
Yeah.
Who would have thought? Well, our audience
talking about stool is always fun.
Yeah, you just throw it against the wall and see what sticks. So with that, I'd like to say thank you to Lindsay Entwine, who's here today. This is awesome.
And I'd like to thank Boo Boo Kitty and Teresa Roa.
Thank you so much.
Patrons. Appreciate it.
And Laura and Bianca.
And we appreciate everybody who...
Good interaction.
And, comments on the channel. We appreciate that.
Yeah. So until next time.
I'm Dr. Wayne Vaughn.
And I'm Dr. Mark Vaughn, telling you...
just finish it. Just finish it.
Just do it.
Don't make a joke. Maybe you should just hold on to it.